I'm Dr. Eric Moore. I'm a head and neck surgeon at the Mayo Clinic, and I'm here with my patient Heidi, who has had a parotid tumor in the past and has undergone parotid gland surgery. Heidi, thank you for doing these questions.
Thank you, Dr. Moore. So one of the most difficult aspects of this entire situation was the time frame in which you're waiting for surgery. It's very, very difficult for patients to get through those days. So I think the thing that helped me the most was the fact that you thoroughly answered all of my questions, but we also talked about what the surgical plan was going to be, because I think the fear of the unknown is very difficult for people. And so I knew exactly what you were going to do. And I think it's important for people to understand that before they go into surgery. So one of the things that seems to confuse people is the difference between a deep lobe tumor and a superficial tumor. So can you explain what the difference of those two tumors are?
Yes, that's a common surgical anatomy description that surgeons use to describe which portion of the parotid gland they're going to remove, and it has big implications for how the patient functions afterwards and how they feel and how they look. So the parotid gland is an interesting gland in that we consider it as two parts, but it's really just all one gland that comes together and coalesces around the facial nerve. And it's the facial nerve that separates the parotid gland into what we call a superficial lobe or portion and a deep lobe portion of the gland. It's the facial nerve running through the middle that causes that differentiation. Now, we always also emphasize that it's all one gland, and it's not really different tissue. The tumors types that occur in that tissue occur both in the superficial and the deep lobe at equal incidence. It's just that there's a lot more of the gland on top of the facial nerve than there is underneath the facial nerve. So it's an 80-20 phenomena. It's not halves. Most of the gland sits above a superficial on top of towards the skin of the facial nerve. So most of the tumors occur in that portion of the gland. But there's also a 20% or more of that gland that sits underneath the facial nerve that's still the same kind of parotid gland that can still develop the same kind of tumors. The reason it's important is because the treatment for parotid gland tumors is to surgically remove them. It's much less invasive, I'd say, to get the top part of that gland, that superficial part of that gland, off the facial nerve than it is to work underneath the facial nerve and remove that deep part of the gland. So if the tumor's in the top part of the gland, surgeons go in underneath the skin through some type of incision, work on that top part of the gland, removing the tumor and part of the gland or all of the gland. There's different philosophies in that and different styles, and we can talk about that. And removing it off of the facial nerve, leaving the facial nerve behind, and relatively untraumatized and unscathed, and the deep lobe of the parotid gland underneath. And then once they've removed the tumor and are complete with the operation, close the skin back over it. Most patients who have removal of the top part of the gland will leave that operation with very minimal sequelae of the facial nerve that are all, for the most part, temporary. So they might or might not have some weakness of their facial nerve branches, causing some weakness of the muscle movement of their face. They may have none of that. They may have it just in one corner of their mouth or eyebrow, but the expectation is that that's all going to return to normal within a period of several weeks, and that facial nerve is going to be okay. When you have to go underneath the facial nerve to remove tumors of the deep part, the expectations are similar in that facial nerve is going to be okay, but it's going to require more movement to that facial nerve to get the tumor out from beneath it, and that movement traumatizes the facial nerve and leads to more temporary postoperative weakness. So when patients have tumors of the deep portion of the parotid gland and we say, we're going to go in there, we're going to surgically remove it, I have a very careful conversation with them about the fact that your facial nerve is likely, it won't be unexpected on my part, is likely to not function normally right after that operation, and it's going to recover, and it's going to come back because we're going to treat it gently and we're not going to cut it, and it will recover from that trauma, but it's going to be more pronounced than if I just took the tumor off the top of the facial nerve, and it's going to last longer and you're going to notice it more.
Okay, so I think one of the other things that concerns patients before surgery is what kind of incision am I going to have? So can you talk about the factors that are considered when a surgeon might be considering the type, the length, the size of an incision?
Mm-hmm. So for the most part, parotid gland tumors are approached externally, meaning some type of skin incision is going to be used rather than going at them through the mouth or from the deep side. There are some unique circumstances where people might try to take out a parotid gland tumor through the mouth, but we really discourage that for the most part. It doesn't give you good visualization of the most important thing in there, the facial nerve, and we want to see that well and protect it. So some type of incision is going to be used. And the art and the essence of the surgery from that standpoint is trying to minimize the cosmetic effects of that incision. So for eons, we've done cosmetic surgery on the face with incisions that we are going to make and then close carefully and design and put in a place where they don't catch the eye and are not readily visible. And parotid gland surgery utilizes a lot of aspects of those incisions. So almost every parotid surgery done utilizes some type of in front of the ear skin crease incision. And when you start to talk about that, you think, well, that's, you're pointing right to a place where I look every day and things like that. But you can hide that incision and make that cosmetically acceptable very easily by placing it in the right skin crease in the right position where there's a natural transition between the ear and the cheek, and the eye is trained to ignore natural transitions and pick up things that cross over and are not natural transitions. And so we utilize that concept to place the parotid gland surgery incision in front of the ear. The next part of that incision usually comes somewhere around the earlobe, where it can also be well hidden, and then what happens next is highly variable in different parotid surgeons' hands. The most cosmetic incisions utilize that underneath the earlobe portion, either keep that very short or continue it and make it longer but bring it back behind the ear, sort of in the facelift style incision to hide it behind the ear and even up into the hairline. And the most common parotid incision done by most surgeons brings it below the earlobe into a crease. How far you bring it below and how far you make it depends on many different factors. For one, it depends on, is there a crease there? So is there some place where you could hide it and make it look somewhat normal? Two, how much exposure do we need? So there are very many parotid tumors where we don't need a big incision because we don't need to see a whole lot of the landscape. We just need to see where the facial nerve is and where the parotid gland interacts with that facial nerve and potentially where the tumor is. And we can do that sometimes through very short or small incisions. But when we're dealing with malignant parotid tumors where we're going to need to take out lymph nodes and all the gland, the surgery is getting bigger, we might need more exposure and we might have to extend that incision.
Okay, so now that we've talked about incisions, how do you typically close an incision, and why do you use that particular method?
So scarring is dependent on very many different factors, and it starts with, one, what we've talked about, how you design the incision to make it look good, and second, it depends on how you make the incision. So most of the time in surgical incisions that we want to have very minimal scarring and look very good, we make the incision with single scalpel blades that are very sharp and make a clean incision and minimize the heat and the injury to the surrounding tissue that you could get from a cautery or something to dry up the blood vessels. We might, in certain patients who are prone to hypertrophic scarring and more problems, even use medications around that incision at the time of making them to calm down the inflammation and minimize the scarring. That's not common, but it's a possibility. Once we've made the incision and placed it appropriately and made it with a sharp scalpel blade and kept the edges very clean, we minimize the trauma on the tissue. So after you make an incision, you typically elevate the skin and put some tension on it to retract it. You have to be very careful how you retract it and what instruments you use so you don't damage the edges of that skin, which is going to lead to more scarring at the edges of those skin. And then finally, when you're done with the operation, you've done all those things, how you close it is important. So you have to bring the tension off the tissue, put it back in its original location, and seal it together in a way that it's not going to leak fluids from underneath, that bacteria from the surface are not going to readily get in, and that it's not going to have big gaps in it. The edges are going to meet each other appropriately. And the types of things that you use to close it cause different reactions in different people. Some people are very non-reactive to sutures or stitches that we use. Some people are very reactive. And so we try to use stitches underneath the skin that are going to cause minimal reaction of the skin to that foreign object, that stitch. The body reacts to all foreign objects. So we try to use sutures that cause very minimal reaction. Finally, after we place those stitches under the skin and we've closed the incision well, we seal the surface, and different people will do different things. Some people will stitch the surface closed also. If you sew the surface of the skin, you either want to use stitches that you get out very quickly so they don't form suture track marks, or that dissolve very quickly. We usually glue the surface of the skin closed. Glue is nice because it forms a nice barrier dressing to the wound, provides some moisture to the wound, which helps it heal. And the last thing we like about it is people don't have to have it removed or taken off by coming back to the office. But this might differ depending, again, on what type of situation you are, where you are. For us, it's difficult to bring people back in a few days back to the office to remove stitches because most of our patients don't live here in this area, but you might be in an place where surgeons very commonly treating people right around the corner, and it's easy to get them back into the office, at which point they might stitch the wound closed.
So there are times where a patient who had dissolvable stitches, maybe part of it will start poking out of the incision, and a patient's first inclination is going to be, I want to pull that out. So what is your advice to somebody that has that situation occur?
Dissolvable stitches are designed to eventually dissolve, but they may not dissolve quickly in every circumstance. And so the stitches that are placed underneath the skin are sometimes very close to the surface of the skin. The skin around the ear and around the cheek is very thin, and it's possible that either you could form a reaction to that stitch and the body tries to deal with things that it recognizes as foreign that it reacts to by getting them out. It may be extruding that stitch, so to speak, or the edges of that just may be coming through the skin. It's unlikely that a person's going to be able to just pull on that and get it off, because even though they're seeing the surface of the stitch, there's probably a knot that's still there beneath it. It's not just going to pull out. If that happens, it's not a disaster. And if people are not close by where we can take care of them, we usually inform them, trim off any edges that are right there at the surface. You're not going to do any harm by doing that. You don't have to try to dig underneath the skin to get it out. And regardless of what happens, it will go away and dissolve eventually.
Okay. So after my surgery, or during my surgery, you placed a drain in there, and it seems like some surgeons do and some surgeons don't. Mm-hmm. So what is the purpose of the drain? And if someone does have a drain, what is the typical length of time that they have to have that drain inserted?
Mm-hmm. So any incision that you make on the body, any surgery that you do, there's going to be some fluid, what we call serous fluid, that's produced by the cells in the area, particularly the muscle in the area, that's going to accumulate in the surgical bed. And fortunately, the body takes back and resorbs most of that fluid. But it can be alarming to people to have fluid underneath the skin. And so our practice is typically to place a drain in that area for a short period of time to get rid of most of that fluid in the first night and morning after surgery. We typically take those drains out pretty quickly so that people can go home. People could, in some circumstances, go home with a drain, but we usually don't do that. But the purpose of the drain is to get that fluid out from underneath the skin. In the first 12 hours, a lot of times it's actually blood that's underneath there, because even though all the blood vessels are sealed, there are still very small blood vessels that will ooze a little bit into the wound. It's not a disaster if a small amount of blood's underneath the skin, but it takes a while to go away and for the body to resorb it, so we put a drain in to get it out. The purpose of the drain is to get that fluid out of there so it just doesn't stay there underneath the skin. If you have a lot of blood that would accumulate underneath the skin, or a lot of fluid, potentially that can get infected or cause pressure on the skin or do things. That's called, if it's blood, it's called a hematoma. Hematomas are not an intended consequence of surgery. That's called a complication of surgery. But that can happen in some circumstances, even though the blood vessels are sealed at the time of surgery. Blood pressure fluctuations after the surgery, patient's ability to coagulate blood quickly or not because of medications that are inherent conditions can lead to hematoma. And that blood typically is not just dealt with the drain. That would require going back to the operating room and getting that out of there so it doesn't lead to further problems. After the drain comes out, then usually right when the drains come out and it's done its job, the area where the surgical bed is pretty flat, we call it. But it will swell in the next couple of days. And so this is alarming to people. It swells a little bit. The skin swells. The earlobe swells. It feels a little full to them. And they wonder, is there fluid back in there? Sometimes there is. And we can talk about what situations that happens in. And sometimes it's just swelling, but most of the time in parotid gland surgery, the drain in the first 12 hours or so is enough, and we'll get rid of the vast majority of the fluid, and the rest of what accumulates in there will eventually be resorbed by the body.
So is the decision to remove the drain based on the amount of fluid that is draining out after surgery?
Yeah, so the parotid bed incision is not a very big bed or incision compared to a lot of the other surgeries we do, and we almost routinely take the drain out the next day. But if the drain was putting out a lot of fluid, then we might decide to leave it one more day. We often think of the drain as, well, if it's putting out a lot of fluid still and we take it out, the body's still going to produce more fluid in there, and then it's going to build up under the skin. So if the drainage was very high the first night of surgery, we potentially might keep it another day, and that would be the reason that someone would have a drain in longer than 12 hours or something like that.
Okay. Well, aside from potentially having a tumor that was cancerous, my second concern was obviously the potential for permanent facial paralysis, and that notion is very terrifying to patients, and it's something that keeps a lot of people from having the surgery because they're so concerned that might happen. And I recall doing internet research that coming away from that, it made it seem like the likelihood of that happening was very high. And, but in my conversations with you, that didn't always seem to be the case. So can we talk about what the actual medical statistics are behind permanent facial paralysis? And then what are the factors that would cause that to happen?
Facial paralysis, regardless of the parotid gland tumor type, who's taking it out, what's happening, is sort of the huge issue in the room regarding parotid gland surgery. And it's very important because the facial nerve is a critical nerve in the body because it controls our muscles of facial expression, which is the first means of interaction of almost every human interaction. And so you want to have normal facial motion.
Yes.
And if the facial nerve is damaged, and we can talk about the extent of and what that means, it rarely, if ever, goes back to normal. But the vast majority of parotid gland surgery does not damage the facial nerve. When I say the vast majority, it's almost unheard of to have permanent facial nerve damage and injury during parotid gland surgery. In fact, it happens intentionally sometimes because you're dealing with a malignant tumor that has enveloped the facial nerve or even caused weakness and paralysis of the facial nerve, which is not going to come back. And the name of the game at that point is to remove the lethal tumor so that more damage isn't done. And sometimes to do that, we have to remove part of the facial nerve. But these are cancerous, bad tumors, often already causing facial nerve damage that the patient is recognizing. And if it's not treated, bad, horrendous things will ensue.
Right.
And so that's a small subset of parotid gland surgery that I think colors a lot of people's opinion. And benign tumors, cancerous tumors that are not involving the facial nerve, which encompass 99% maybe of parotid gland surgery, the expectation is that the facial nerve will not only work, but work normally eventually. And the key concept is that there might be some weakness and trauma caused to the facial nerve right after the surgery, but that should all recover unless the facial nerve was damaged significantly, which doesn't happen in routine parotid surgery.
Okay, thank you. I think you provided a lot of peace of mind to people that might not have this surgery because they're afraid of having that permanent facial paralysis.
I think it's the number one reason why people elect not to have their parotid gland tumor treated, because they feel like they're going to have that outcome and it's never going to get better and it's going to be permanent. And I think the key thing is that parotid gland surgery can be complicated. You definitely want to make sure that it's being done by someone with experience, because experience breeds good technique, which breeds good results. But most people who are offering parotid gland surgery will be able to do that surgery well for the patient, and the expected outcome is normal facial nerve recovery.
Thank you.